Okay, hello everyone. We are back and it has been a fantastic day. This has flown by and we are in for our last and exciting panel. So I hope everybody is ready to go. We have all our panelists here and I want to introduce our final panel of the day, value-based care and changes to pain management policies. This is another exciting group, reflections from a large commercial insurer, employer, and an insurance reform expert living with chronic pain. I want to introduce Denise Giambalvo, who's moderating today. And Denise is Vice President of the Midwest Business Group on Health. And I know she will share her summary and the work we've been doing, but I just want to add before I turn it over to her and the rest of the panel, really what a pleasure it's been working with Denise through her interest and motivation to figure out how best to implement value-based care. We have built partnerships that have grown into some things she'll share and new things for the future. And I share that because I think it's just important as a theme I've heard in every panel today. So much of this good work as we're trying to change culture and shift policy and practice really does begin with us and where we see our interest and our energy to put forth. So again, thanks to Denise and all the rest of the panelists, and I will turn it over to you.
Thank you, Amy. We could go to the next slide. It's so nice to be here with all of you. And in case you're wondering, my background is of Lake Michigan. I live on the northern end in just outside of Chicago. Before we get started, if it's okay with you, I'd like to share a little bit about Midwest Business Group on Health. MBGH is a 501c3 that has been in existence for 40 years. Our membership consists of over 130 organizations from mid, large, and jumbo fully and self-insured employers, private and public, including manufacturers, coalitions, hospitals, health plans, and the list just continues to go on. Our members provide coverage for over 4 million lives, with the employers spending more than $12 billion annually on health benefits. With our primary focus on education, we provide opportunities for networking, surveys for benchmarking, employer-directed research, toolkits, and pilot programs. Our community-based initiatives range from health improvements to quality outcomes. We work with buyers groups and health benefits service offerings. Next slide, please. And so why are we interested in integrative pain management? How does this apply to employers? So MSD accounts for approximately $20 billion per year in direct costs for employers. The indirect costs are around $100 billion per year. So indirect would be absentee and presenteeism, any type of impact on reduction in productivity. In 2018, 65% of HR professionals reported opioid addiction having a financial impact on their company. 55% of the US population is covered by employer-sponsored health plans, and employers can influence the adoption of integrative pain management. They have the ability with covering 55% of the population to leverage their collective voice and help to get the change going. And as I'm looking at this and I'm quoting dollars and percentages, I don't want to lose sight of the fact that there's a person at the center of all of this. And I don't think there's a single employer that I work with that is not focused on their human capital and how important those people are to their organization in a total health and well-being perspective, which is why us partnering with the Alliance to advance comprehensive integrative pain management has worked so well for our organization, because our employers are very interested in a comprehensive approach to medicine for their covered population. In March, we partnered with AACIPM and facilitated an employer advisory board. It was a great opportunity for us to bring people together, for them to learn more about evidence-based, patient-centered pain management. We also had the National Alliance there with us and the Kentuckiana Health Collaborative. So for us to be able to engage other employer coalitions, and National Alliance actually represents membership of employer coalitions across the country, to be able to have them at the table along with individual employers is really helping us to gain momentum in this area. And key learnings that came out of that advisory board are that employers do care about the whole person. And more education is needed for purchasers to understand evidence-based multidisciplinary pain care. And when they're provided with that information, we actually see a shift in the employer's perspective. Each one of them opened up to new thought ideas and walked out of that room with some creative notions on how they could somehow bring their population closer to integrative pain management. So with that bit of background, I don't want to keep you from our wonderful panelists that we have today. So we will start with Jason Perot from the Boeing company. He will share his story of the wonderful work that they're doing there. And I am pleased to turn this over to him. Jason is very active in our coalition. He's the chair of our board. Boeing has been a member for many years, and they lead the way for employers across the country.
Thank you, Denise. Okay, well, I just wanted to share briefly some approaches that the Boeing company has taken over the last 5 years in our efforts to, I would say, deploy a comprehensive strategy across our benefit supply chain, looking at recommendations spanning medical, PBM, dental, behavioral health, and EAP. So what we did was we started with this chart that really kind of outlines providers, suppliers, workplace as the three swim lanes or rows going from left to right. And then when we think about the continuum of opioids and pain management, we think about prevention as one category, early detection as a second, treatment as a third, and fourth is return to function. And where we saw, I would say, the biggest, most significant opportunity out of the gate was on the prevention category. Just to get started, we submitted a comprehensive questionnaire to our supply chain to really understand as a baseline, where are they at today for current state? What are their strengths and assets, and what are their gaps and opportunities to improve upon? And we did solicit our medical plan administrator, PBM, dental plan administrator, behavioral health, which was carved out at the time, and our EAP vendor. And really that informed us on what actions we could potentially deploy across all 5 suppliers when we think about this grid in place. Out of the gate, what we started in 2015 and kind of iterated over time into 2020 was a more comprehensive approach around the PBM channel in particular. When we think about opioids, we tackled a few different areas around it. First, we started with average day supply, and we imposed a limit on that to 5 days supply. If there was medical necessity reasons, we offered an out by which there would be a coverage review that could enable our members to get up to 4 subsequent refills if necessary based on medical necessity. Otherwise, our view was, let's face it, the vast majority of cases may only require 1 to 3 days of opioid supply, and that's it. And in many cases, we could find opioid alternatives. So how can we kind of leverage that in those particular situations that are more, clinically appropriate to do so? The other thing that we deployed beyond the 5-day supply limit was 120 milligram morphine equivalent daily dosage limit. And that was all put forward in 2018. And over 2019, as we learned from the data, we were very effective in reducing the average day supply year over year, as well as mitigating the risk around opioid dependence and addiction. On top of that, for 2019, we went one step further. We ratcheted more tightly the day supply down to a 3-day supply limit for first-time patients prescribed opioids. And we lowered the morphine equivalent daily dosage in milligrams from 120 down to 90. And that went in place, the 90 went in place in April 1st, 2019. And the 3-day supply limit for first-time scripts went in place on October 1st, 2019. We kind of staggered that out. And over time, what we've seen with these steps that we've taken from an employer standpoint is there has been zero noise, zero issues with our workforce around this. In those one-off cases where clearly there's a need for a greater day supply, those cases are being handled on a case-by-case basis. And overall, we've greatly enabled our workforce and their dependents, for that matter, to mitigate, the unnecessary risk and an overprescribing of opioids that we've seen for far too long. Beyond that, there's been a significant financial savings to that. And this isn't really about the financial outcome. It's really about the health outcome and the quality of health. But, that's been, the other aspect that has served us well financially when we look at not just doing the right thing for our members, but also, looking at that aspect on the back end. Beyond that, I would tell you, we've also created a education letter to serve as an outreach to not just our members that are newly prescribed opioids, but we also have an interventional outreach to the prescribing physicians to help ensure that the day's supply, the script that's being written or prescribed is certainly medically appropriate based on the nature of the condition and what is trying to get, resolved and remediated. That also, and that dates back to 2015, 2016, when we launched the educational outreach campaign and kept that in place even to this day. We saw a 30% reduction in opioids dispensed to our members that were first-time scripts. So as we kind of took these learned lessons, we kind of put it all together. And when we look at the fentanyl category, we saw relatively loose prior authorization criteria within our PBM for that category in particular. We saw some doctors that were providing scripts for off-label use. In many cases, the products were FDA approved for cancer pain management. And we discovered that some of the members were getting access to these products that were not cancer pain management. So by virtue of, the true intent behind these products, we took a more customized approach to tightly manage and tighten up the criteria around the prior authorization criteria for the entire fentanyl category. And we saw a substantial reduction in the volume of fentanyls dispensed to our members as well. One step further on the dental side, we took an industry first effort on working with our dental plan administrator to truly uncover what's truly going on with opioids flowing through the dental channel. Unfortunately, nearly 1 in 3 adolescents, teens, young adults are getting opioids for the first time through the dental channel for molar, extractions. and other oral surgeon type work. And what we discovered was there was great variability in the prescribing patterns of oral surgeons in particular when we looked at not just state by state, but down to the county and down to the oral surgeon level. What was truly going on was pretty eye-opening to us. And from those learnings through the data, we conducted collaborative outreach and education campaigns to target those specific dentists, specialists, oral surgeons, to help them understand based on their prescribing patterns how they kind of varied as an outlier relative to national averages. So we created heat maps. We also conducted partnerships with down to the municipal level to conduct education campaigns through our dental plan administrator to facilitate those logistics. And in the end, it's a journey. We continue to learn from the data. Our hope is that over time, we'll be able to quantify improvements in the prescribing behaviors and patterns in the dental channel alone. And hopefully, you know, we'll see some market improvements over time. We're just entering in year 3 with that effort, but it was a collaboration between the pharmacy claims data flowing through our PBM and leveraging 2 separate parallel data analytic firms to help us kind of understand what's truly going on in the dental line of business as well. So those are a few things that have been very impactful, again, to mitigate the risk and serve the purpose of helping our members and their dependents and loved ones avoid some of the risks that are, you know, clearly evident within this, you know, area. I'll pause there, Denise, and, you know, open it up, or, you know, happy to add any color or context if need be.
Thank you, Jason. Yeah, I appreciate all your comments, and I think that they would like us to move on to the next panelist and come back for questions at the end. So if you'll, you know, remain on the line, and we'll go to David Elton now, Chief Strategy Officer with United Health Ventures.
Great, thanks, Denise. Jason, thanks for breaking the ice on no video, so I'll spare everybody or leave it to your imagination what my COVID self-inflicted haircut, how that worked out. So we'll go no video. So thanks. And Amy, thanks to you for the invitation to contribute, and well done on logistics and technology. I think this has really worked out well today. So nice job. Here's a picture of our orthology clinic, which we'll talk about later, but let's go to the next slide. So by way of disclosures, UHG since 2001, currently sit in United Health Group Ventures, Chief Strategy Officer, chiropractor by clinical background, and email in the event those may want to reach out after. And next slide. And context, you know, we're going to really quickly get narrow on a topic. The broader context is UHG's response to the opioid epidemic and COVID pandemic has really been comprehensive, sustained, high impact, some of which is known and much is truly behind the scenes, but high impact nonetheless. And for those that want to read a little bit more, here's some links. But let's go to the next one. Next slide, please. Similar to Jason, you know, when this opioid epidemic sort of was sprung on all of us back in 2015, we commissioned the Opioid Task Force. And moving from left to right, we organized the task force around 3 work streams: preventing addiction, treat addiction as a chronic medical condition, and then support long-term recovery. Each of those work streams was then broken up into multiple areas of focus. And for the prevent addiction work stream, you can see the areas of focus here. And each area of focus, then we commissioned a work group of colleagues within the enterprise and then external subject matter experts that we brought together in a just ongoing, sustained, sort of accountable project. And this pain management work group continues to this day on a weekly basis, so quite active. And in a couple minutes here, I'll share a little bit of the work that's spun out of that work group. So let's go to the next slide. So I think, we've covered a lot of this ground already today. I think it's probably familiar to most of us. Pain management work group, as we look at the science and the data and our own internal data, pretty quickly, all roads lead to back pain as a high priority area. Common source of disability, prevalence is high and increasing. 45% of low value care is associated with back pain. With regard to today's topic of pain, 75% of prescribed opiate MMEs are for musculoskeletal conditions and about 50% is for back pain. I think earlier is referenced as a payer or insurer. This is in an employer. This is typically one of the larger spend categories, and well-known rate of surgery is highly variable due to a number of factors. Let's go to the next one. The good news on back pain is that the guidelines are really clear today. And we've broken this up into first, second, and third line treatments, and I think all of us are pretty familiar with this. First line, reassurance, natural history is your friend. Let's understand the condition, keep active. And then we move into the second line treatments as patients engage the delivery system, and this is where the guidelines are universal in recommending PT, chiro, acu, massage, yoga therapy, nutrition, mental health. Quick editorial sidebar here is you think about the labels applied to many of these therapies over the years. It started with alternative, so okay, set aside maybe complementary, then sort of welcoming into the tent, then integrative, and one could make the case, given this guideline support, that these therapies maybe ought to be flipped to primary as in terms of a label, which then leaves what do we call the third line interventions, surgery, the imaging, injections, and prescription medications. But the framework on these guidelines generally breaks up the approach into these three stages. Let's go to the next slide. And we'll get into a little bit of data and unpack this from the view of a payer. And we know that for musculoskeletal conditions, there are many competing care options out in the market that, in Minneapolis here, you drive down the freeway and boy, you've got billboards for orthopedic centers and pain clinics, and it's really hard for consumers, patients to navigate all these different choices. If we look at back, neck pain, and then lower extremity and upper extremity by the three pathway options, with first being the self-care option, not great data. We really don't know what that looks like when patients engage in self-care. So let's focus on 2 and 3. So patients that start with a conservative path, most often PT, chiro, acupuncturist, and then what percent start with the more interventional path, which often is a medical provider or specialty. And while the guidelines are really clear, what's fascinating is 29% of back pain starts on a conservative path, 71% starts on a real interventional path. And the total episode cost differences are pretty profound. And that's driven by, as you can see, the differences in use of imaging, opiates, injections, and surgery. And when you flip over to the extremities, it's even more concentrated on sort of avoiding this conservative path and going straight down the interventionist path. And the cost consequences are similar. And earlier, there was some discussion around the CBA or cost benefit analysis on if we drive more conservative, what's the total cost of care savings, and how can we roll that into sort of different incentives and so forth. But these are sort of the underlying economics you look at, that when you're looking at $1,500 cost of care difference for pathway 2 versus 3 on back pain, with only 30% starting on the most conservative route. The potential cost savings are dramatic, not to mention the ability to reduce use of opiates and imaging and injections and so forth. So back to the pain management work group, as a payer, we step back and think, this is a multifactorial problem, but what role do benefit plan designs play in either incenting sort of the behavior we would hope patients may take, or creating barriers or disincentives? And let's go to the next slide. So that work to understand benefit plan designs, we've been looking at that as long as the opioid task force was spun up, so back to 2015 and even earlier. But we had a nice opportunity to partner with BU and the APTA, and UHC and Optum came together to sponsor some research out of Optum Labs. A couple findings from this research, and the citations are in here. For low back pain, patients are 75 to 90% less likely to have short or long-term opiate exposure as first contact is with a chiro, PT, or licensed acupuncturist. And then we were also able to demonstrate that as copays and deductibles increase, patients are less likely to choose that care option compared to choosing a PCP as their entry point. And so we went all in on that and said, well, as a payer, we can look at benefit plan designs. And so down below, you sort of see a sequence of items where in July of 2019, we began to introduce benefit plan designs that eliminated patient out-of-pocket costs for patients selecting chiro or PT for treatment for their back pain. And that really in earnest, we started communicating and engaging and pushing in late October, which will get relevant here in a minute when we should talk about what's the impact been. And in the middle here, some of the direct to consumer and through employer messaging we did to help sort of create awareness of back pain treatment options. What do the guidelines suggest, and what are employers doing to make it easier for patients to select conservative care where it makes sense? And then in terms of rollout, this is a staged rollout over multiple years in different markets across the country. And in July of 2019, we rolled this with about 500,000 members. 1/1/2020, we're up to about 1.5 million members. July, we have another tranche going that'll bring us over 2 million members. And then 2021, where this really accelerates in the ASO book, we're approaching 5 million members with this benefit plan design. And there's some other links here to other press and news and content on what this benefit plan design is. But the bottom line is, let's just take down copay and deductible barriers to patient accessing these conservative care options for back pain. In the next slide, we unpack a little bit here, what has the impact been? And qualitatively, we've received really positive feedback from employers that now have this choice in configuring their benefits that, okay, it's about time, somebody gave us this option. The reaction from members has been similarly really positive. It's like, hey, I use these therapies, there's a cost burden. This is great that the cost burden is coming down. And the way this is rolling out with different blocks of members in different markets sets up a number of different control groups, which for the researchers on the call, that is helpful for sure. And then we have a really ambitious measurement plan through our actuaries and healthcare economics teams to understand what kind of pathway shift is being created, the rate and timing of introduction of second and third line services, what's the net dollar impact of waiving out-of-pocket costs. And some limitations important before we get into the data is we're still dealing with a really small number of members, which sort of been a common theme on some of the earlier presentations as well. So we are dealing with small numbers so far. The benefits really started to roll and become emphasized in October of 2019. We have claims data through December, so really limited window. And then we'll talk about COVID in a minute. But with what limited data we have, the chart to the right compares the pilot group that has this benefit with a control group in the same market of commercial members, similar demographics that don't have the benefit. And then we're comparing the post-rollout measures with a 12-month pre-rollout baseline measure of different attributes of spine care. And so we're comparing 1/4 of data with the new benefit to 12 months baseline pre-rollout. So that's important as well, in that it introduces some static in here. But moving from left to right, what we find is the percent of patients accessing chiro or PT, the percent of patients receiving imaging, or the percent of patients with back pain receiving an injection, minor puts and takes, but generally no big change there. But then we move into percent with opiates, percent with surgery, and then total cost of care. We start to see some differences. And if we look at opiates for a minute, you can see percent of opiates in the control group for back pain down 20%. That's consistent with just general reduction in prescribing. Percent with opiates and those with this new benefit is down almost 40%. In surgery, percent down 5-7% in the control group, a 50% reduction in spinal surgery in the pilot group, and you can see the big change in total cost of care for back pain. So no, really can't draw any conclusions from this yet. We're measuring it. We'll share this more as this sample size grows. And let's go to the next one. And we've got 2 minutes here to finish this up. So COVID, wow. So our measurement plan was sort of blown up here in the first quarter, and an abrupt 50 to 75% reduction in visits to PTs and chiros nationally. We really quickly, and actually had a CMS, expanded telehealth coverage to include PTs and chiros, currently in place through June 18th. We're evaluating that weekly. Originating site waivers in place, patient out-of-pocket costs are waived, thousands, tens of thousands of telehealth visits. And what we know to be true is patients appreciate it. But I think the jury's still out on how effective is this for these therapies, and introducing a screen between the patient and the person where we can't put our hands on people. I think it helps with continuity in the near term, but long term, we'll see. And we do have a grant proposal submitted to study the impact of the benefit plan design, COVID, and effectiveness of PT, DC telehealth. And if awarded, I think that's going to be some interesting and important work coming up. Let's go to the next one. So that's kind of work we've done through the payer side. Similarly, we've made significant investments on the provider side, thinking we're potentially going to have the greatest impact coming at this as a provider. And one way this is manifest is through our orthology business, which is where I sit today. And we're scaling the AACIPM practice we were always hoping would emerge in the market. And this practice consists of 3 components, 3 primary components. Really great, engaging digital tools to support the first line treatments that are really important. Then the second line treatments, in-person telehealth, integrated multidisciplinary PM&R, PT, OT, chiro, massage, acu, yoga therapy, nutrition, mental health, all in an integrated clinical practice. And then this practice is surrounded by this idea that we need to engage with the local delivery system. So when third line treatments are needed, we can help patients access right treatment, right provider, right time, as quickly and as efficiently as possible. And so this orthology practice is exactly this. But the goal really is to do this at scale. I think it's complicated enough to do one of these, but to do thousands of these all across the country is the path that we're on. And that's a whole different challenge unto itself. That's a topic for a different day. But the next slide will sort of wrap this up here. And so the orthology practice is built around this idea that we want to have scaled, convenient access to these conservative pain management services. And then carefully in local healthcare system ecosystems, how do we connect that practice to the local medical environment such that we have coordinated triage and scheduling to get patients onto the right pathway as soon as possible. Following the eval and triage process, we can recalibrate the pathway and optimize the setting based on what we unpack in the eval, get patients onto the right care pathway, and then as treatment is unfolding, there's a continual setting optimization as patients have different needs, and do that in a collaborative way with the local medical system in each market in the country. And then take a really expansive view of impact on movement, on health and well-being. And this has come up today multiple times: sleep quality, resilience, coping, BMI, blood sugar control, all of which are associated with better movement and activity and ability to engage in work. And so our measurement plan is much more than just measuring pain or change in an oswestry score, but take a real expansive look at impact on health and well-being. And with that, I think I'll leave you with some citations and hand it off to Daniel. Thanks.
Thank you, David. So yes, now we have Dania Palanker, Assistant Research Professor at the Center on Health Insurance Reforms at Georgetown University. Dania, we look forward to hearing from you.
Great, thank you. And thank you for having me. So on to the next slide. I will let people know. So I'm sort of approaching this as a combined piece, both from an individual living with pain, but also a health insurance policy expert. I work at Georgetown University studying health insurance reforms and have also specifically studied some issues around health insurance coverage for pain treatments. And the next slide, I start a little bit with my own story of someone who has been living with pain since I was 14. And it's pain that sort of has continued and changed throughout my life. And really much of my life, I didn't think of myself as a person who lived with pain, but I was during that time still trying to access the healthcare system, trying to get diagnoses, just not sort of putting things together that I lived with pain. And the next slide, it's really when I got to the point of learning that I had chronic pain, and then in 2003 getting diagnosed with fibromyalgia, that it sort of pushed me down this career path to do health policy, actually. And I put this up this picture is not to promote any political candidate, but I was there as a celebration of the Affordable Care Act anniversary. Because really what happened is I got diagnosed with fibromyalgia, sat in the car and cried. And in that 5-10 minutes of the beginning of crying, came to the decision that I was going to apply to law school, because I realized if I don't do it now, I may be disabled later in life and I may lose that opportunity. And it was a year into law school and realizing I did not want a career in tax policy that I realized that my own struggles in accessing healthcare, even with great health insurance, is sort of what led me towards having the decision to go to law school. And so that also brought me to health policy and really ended up bringing me to health insurance policy in particular. So that's a little background on me. And I want to now on the next slide, get into some of the research that I've worked on and others have in this area of really looking at private insurance coverage of pain treatments. And I think the first is really, we still have to remember a lot of our private healthcare system is a fee-for-service model. And what that really has done is it's encouraged, shorter physician visits. And, some people we talked to about in some of the research I've done, particularly to the opioid crisis, has even been that some say that fee-for-service encourages prescribing opioids because it encouraged, at least at one point, a quick prescription because you would have that short visit rather than the longer term type of management that someone with chronic pain really needs, that there's limited or no coordination between providers because that's not paid for by a fee-for-service model, and a lot of what you had was doctor-provided interventions. We also have, I think, the huge piece to talk about that's been talked about a lot in the last part of the discussion were a lot of the rehabilitative services. And when you think about that, physical therapy is almost always covered in insurance. I think we would be shocked if we found a plan that didn't. A study a couple years ago by Hayward in JAMA that looked at public and private payers found that 98% covered physical therapy. I think there was one plan he looked at that didn't. And then some of the other types of rehabilitative services are a little less common. So chiropractic is something that has become very common, although I'll have to say was uncommon back in my first time having insurance back in the 90s. It wasn't very common, or my first time choosing insurance, I should say. But now we're at a time where he found 89%. A study I did with Dr. Robert Bonakdar that looked at the essential health benefits, which is what individual and small group market plans have to cover, found that 46 states' essential health benefit plans included chiropractor. In comparison, acupuncture is getting up there, but it's not there yet. We only found 5 state essential health benefits had acupuncture, and Hayward only found about a third of plans covered acupuncture. The other thing is a lot of these services generally have limits, and they can be very high, like 50 limits per year, but they can also be as low as 10 visits per year, which is problematic when you have someone who might have chronic pain and needing services, as well as having the problem of maybe they also have a heart attack and need cardiac rehab that year, or they happen to sprain an ankle that year and they hit their limits. And then a couple other pieces that are important is, first of all, some of the integrative services such as massage therapy are a lot less common. We only found a couple plans in the state EHBs covered massage therapy unless it was provided by a physical therapist. And the other thing is, it's in the name, it's rehabilitative services, which means it's for people to rehabilitate. And once they are at a certain level, or if they're never going to improve, but that therapy is just maintaining their function, it's keeping their pain from getting worse, some payers will actually stop covering at that point. So on the next slide, what I want to talk about a little bit is there's also some common exclusions that people find. One thing that we found in our look at the essential health benefits is there's often blanket exclusions on complementary and alternative medicine without really clear definitions of what that is. Pretty much every plan excludes experimental services in their plan. The reality is certain things that might be considered experimental are going to have to be covered. The reality is we don't have a lot of data on a lot of pediatric services because we don't want to study things on children. But of course, those services will be covered. But that also becomes a big area where I have heard of complaints about some of the services we talk about today, or some of the services that people or doctors want to have covered end up being denied as experimental. And I will note that also happens in the traditional medicine path. There are people who are trying to get IVIG for small fiber neuropathy, and that gets denied as experimental. So it's really the whole breadth of services, but it's definitely an issue in integrative and complementary care. And then there are exclusions for exercise outside of physical therapy. So things like yoga are not covered because it has not been seen as a healthcare service. And also, as I note down, the last thing here is that providers must be licensed. So you don't really have licensed yoga providers. So, in some states, you might not even have licensed massage therapists. So some of these services really, and that's an issue that the work and that evidence grid has found has been problematic actually, is that providers of services, if the state doesn't license, it's very hard for insurance companies to cover. And then there's network limitations. Mental health, behavioral health provider networks are not as strong as we would hope. And the reality is there are very few providers in here that specialize in pain in general. And so there probably aren't enough providers who specialize in pain, let alone those who are in networks. And then if you start to try to look for physical therapists who specialize in pelvic pain or specialize in Ehlers-Danlos syndrome, those are the type of situations where people can have network limitations in finding the providers they need. And I want to quickly on the next slide talk about just some other types of insurance that are out there, or insurance-like products that have been getting a lot of news lately. And these are alternative coverage options that are really limited generally, and also with chronic pain. Short-term health plans, which are meant for short gaps in coverage, but people might be buying them now for up to 3 years at a time. Healthcare sharing ministries, which aren't even insurance, they don't guarantee coverage. And fixed indemnity health plans, which are really meant to wrap around your insurance, but are being sold directly to consumers right now as their only coverage, and will do things like pay $100 per day for hospital, or $50 per doctor visit. And some of these have really specific exclusions for chronic pain. They all exclude pre-existing conditions. So the reality is someone coming in with chronic pain, if they can get past the underwriting for short-term and fixed indemnity, if they're able to get through the door, they're not going to actually have that plan. They're not going to have their pain covered. And then there might also be specific services that these generally exclude many more services than comprehensive insurance does. So on the next slide, I want to get back to my personal story and talk a little bit about where I have been in my access to some of these services. I've actually been very lucky my entire life. I've had access to very good insurance, and I've always had what has seemed to me like very good insurance, but there have still been areas where I've sort of hit a wall in access to coverage. For probably about a decade, I paid out of pocket for a physical therapist because I could not find a physical therapist in network that would spend 45 minutes working physically on me. I didn't know how to go about and find that in my network. And so I found one out of network, and the amount of money that I would get reimbursed was so low that I quite honestly just paid for it all out of pocket. And it took me years to find a psychologist, someone who did behavioral health therapy for specific for people with pain and for pain treatment, and let alone one in network. And I call her a unicorn because she actually does take insurance, which is very rare. And I honestly only found her actually because of my involvement with the Pain Congress last year and being able to reach out to someone I met there who gave me a referral, who I finally found her. And I think much more recently, I've grappled with an insurance issue. I actually right now, if it were not for the COVID pandemic, would be at the Mayo Clinic in their pain rehabilitation program. And trying to get my insurance to pre-approve that was a roller coaster of an experience for someone who who knows health insurance and knows what questions to ask. And really what it was Mayo Clinic told me that they had stopped allowing people with my insurance carrier to attend the program because the insurance company would initially look at it. It appeared like it would be covered in all the paperwork, but then the claims would get denied, saying it was actually a vocational and educational program. And I eventually was able to get they don't do a prior authorization, for this, but I got them to do a predetermination, which even then I have to say, I think there's a good chance that I got that predetermination because I know someone at the insurance company, because I do health insurance policy, because they made it very clear that they don't normally do the predetermination. Either that or I was pushy enough to get to the right person that I was able to get the predetermination. But that's, to me was concerning because here there's very few of these programs that really do the comprehensive integrated care, which is why I had to look out of state. And that the reality to know then that, you've got this crisis that it's billed in a way that my insurance company is so not used to. They couldn't even figure out why it was that they would consider it to be a vocational and educational program. So, I'll return it to Denise. Hopefully we have some time for questions.
Thank you, Danya. That was really fabulous what you shared with us. We do have time for questions, and the engagement is just wonderful. I love all the sharing that's been going on in the chat while each of you has been presenting. So fee for service is a big topic. And we appreciate you bringing that up because it's definitely created barriers for people to get access. And there's a comment here. Now that we have virtually created an opioid crisis by our mismanagement and that opioids are now restricted and criminalized, the opioid reliant patient appears to be swept up in the damage as well. And this is due largely to the fee-for-service system that leads to prescribing, performing interventions, and doing surgery. And so not only does fee-for-service not serve the chronic pain patient, it doesn't serve most of our patients in the system. And definitely we need an overhaul. So if you're not familiar with Catalyst for Payment Reform, I suggest you go to their website and see the work that they've been doing to try to advance alternate forms of payment, and they've been working with the employer community to try to get that going. Jumping back to Jason, when you were talking about limiting dosage for opioids, the question was asked, for certain percentage of patients, they will progress to chronic pain for which long-term opioids will be necessary, sometimes at a high dose. How do you deal with such circumstances, considering the restrictions that you have in place in your plan design?
Yeah, so what we've been able to demonstrate over the last 2+ years is close to a 95% reduction from long-acting opioids, pivoting those prescribed that over to short-acting opioids. Pretty substantial when you think about, that that conversion success rate. Clearly, we have, I would say, a need out of medical necessity for some of our people to certainly have long-acting opioids, and we certainly allow that to happen. But we do have, I would say, a more rigorous approach in place for the last 2+ years to help facilitate the appropriate short versus long-acting opioids for our members.
Thank you, Jason. David, I've got a question for you. So musculoskeletal, here's the David Elton from United Health Ventures focused on musculoskeletal pain, and I wonder how they view and cover multi-symptom issues related to CRPS and RSD.
You have to unpack those acronyms for me to make sure I know exactly what we're talking about.
Yeah, so I actually need someone to unpack them for me too, because when I was looking at them, I was like, not certain. So is there someone else on the line? Amy, can you unpack those for us? CRPS, RSD?
Yes, regional symptomatic dystrophy.
Okay.
Yeah. And David, that's okay if that one's taken you. Are you familiar with that?
Not familiar enough to offer an answer in front of all of these knowledgeable
Oh,
people.
absolutely.
We can get back to them on that.
Yeah, and we had, Denise, I'm not sure if you have the questions also we had from before. So, and this is Amy, I'll Dave, just to kind of add on to another aspect of the question, I think there's a question around the multidisciplinary approach that you're describing, specifically, how, if it includes coordination through a case manager or team approach, or if it's individual services.
Yeah, so I think, and I did type a response, I think whoever asked that, so the way we're viewing it is we do have this menu of services available in the clinic that, patient preference sort of drives the entry point on which type of provider they would like to see for their condition. And then we calibrate the services we make available based on what we identify in the intake. And we do have surrounding our practice what we call a care navigation function, a team of people that help people navigate their choices in the clinic. And if we don't have what a patient needs or wants, we are connected to the local ecosystem to get people where they should go as quickly as possible and facilitate that referral. So we kind of view that as sort of a case management function and an advocacy function and a help people navigate the local ecosystem function, all sort of in one package.
Thank you. There was a comment here, and actually this is something I just learned the other day, and that is that acupuncture is an essential health benefit in 6 states. I have a niece who's studying at Berkeley and had notified me that it's actually considered primary care, and they bill as primary care there. And so I think we need to spend a little more time looking at that, to, at least from the employer perspective, to make it, bring the lessons learned to them from those 6 states.
And Denise, potentially to add to that, perhaps just with Danya and David speaking about this from different perspectives, I know in terms of essential health benefits, which Danya mentioned she did a study on, and David, I think it's interesting too, Danya mentioned, for example, yoga therapy, is not widely covered based on licensure and issues around that. And I'm just pulling out one example, because I know we get a lot of responses, on these messages. But the question here is perhaps, David and Danya can each make a comment about that from their perspectives, because where I'm trying to go with this is that I think that there are some common themes, but then there are individual responses like UHG and others are doing. So perhaps each of you could unpack that a little, if that makes sense, to kind of connect some of the facts and realities with how that's playing out.
Sure, Danya, do you want to take a run at that first?
Sure. And first, I'll note with the essential health benefits, that's what these individual and small group market plans in states have to provide. And quite honestly, they're in almost all states, they're based on the largest small group market plan or one of the largest small group market plans in the state. And they really, I think, were not necessarily chosen for the detail of whether acupuncture was covered or not. There were other bigger issues around market issues that were often part of the analysis by the states, and some states just went to a default and didn't choose. So I don't think a lot of states did an analysis of whether or not to include acupuncture, but it's, I think, an important piece to compare that. I think you have, almost 90% of states require chiropractor. Versus acupuncture is really just more a piece of where the insurance market was and has been, where they've really widely adopted chiropractic care. But acupuncture, I think, has been a much smaller adaptation that's growing. And I think that even right now, I would say that we're seeing I think a movement, even where we see it today, where carriers are looking at some of these services to start looking to say, wait, is this a better way of providing pain care, both a lower cost and a way that keeps people off of prescription medications or will reduce the prescription medications?
Yeah, so when I joined United in 2001, we were providing acupuncture coverage. We had a decent network that's grown to about 10,000 licensed acupuncturists nationally. And to Danya's point, we're seeing interest among employers grow in adding that benefit. And as our BMJ paper revealed, the benefits of acupuncture therapy, at least for back pain, it's really pretty compelling. And so I think that's just going to continue to grow. To the yoga therapy, we've been really pleased to be working with the IAACIPM around integrating yoga therapy into the orthology practices. And these yoga therapists are highly trained, really exceptional clinicians that in some channels it's third-party reimbursed, it's others it's out of pocket. And in the ground floor of the building I'm in, which is our UHG R&D building, we actually have a dedicated yoga therapy room, and we'll be starting to run trials on integrating yoga therapy into care plans for patients and go deep on understanding the long-term benefits of yoga therapy, which is sort of the roadmap to this becoming a covered benefit, is prove some of those things out. So really excited about layering in yoga therapy to our work.
Thank you. I know that there's a great deal of research going on with that at Duke. I don't know who else is doing work in that area, but I suspect that we're going to start seeing that advance rapidly. And do we have time for one more question?
Well, I think we have to wrap it up. We just want to close and let everyone go after this long symposium. But thank you, Denise.
You're welcome.
Yeah, and thank you to all the panelists. This was just fabulous, and I think a great way to end our day. And as we said before, we will send answers to questions that were not yet answered to everyone. Kevin?
And I think start on time, end on time, deliver what you promised. I certainly appreciate all the panelists today. It certainly met our symposium objectives to date. Highlight leading examples of innovation and progress in this person-centered, multidisciplinary, team-based pain management. Provoke thoughts and discussions from the chat that's going on. I think we're doing that. Coalesce the group around a common understanding of available evidence. That's a work in progress. And then gather input on what should go in that repository. And so we're adding to it today. So progress even in the afternoon. We'll continue this tomorrow. If you're not going to be here, please do your post survey for us so we can collect some your feedback. We will see everyone tomorrow virtually at 11 o'clock Eastern. And Alexis responded to me from the hallway for some reason. And I appreciate the fact that we didn't have a lot of technical glitches. And it's thanks to the planning from the team, and thanks everybody for cooperating. So without further ado, we'll let everybody go home if you're not already there, and we'll see you tomorrow at 11 a.m. Eastern. Good night.